My 4-year-old daughter has been on Omeprazole since birth. She has been handling reflux issues well and has been on the same dosage since she was 2 years old. Should she be weaned off it, and can reflux come back again if she's taken off the medication altogether?
Well, again, we have to start at the beginning. You know, why is she refluxing? Because that will influence whether she can come off it or not. And then the second question is she refluxing? She may or may not be. Many parents are very persuasive, and actually I believe them because I talk to them. And if they give me the legitimate symptoms, and that's absolutely fine. But then one has to do a diagnostic test to understand how much reflux there is, and then one has to make a decision whether it is worthy of treatment or not. I think the treatment strategy here, letting someone grow out of their drug, is probably not unreasonable, to be honest. I think we've all done it, because the natural history of reflux varies depending on the cause, and you know, some do get better, some don't. But there probably should be something measurable that you do, which is not pleasant. I mean, Lord forbid, the gold standard test involves sticking a tube down a child's nose for 24 hours, and I can say it in that way because I've done it to I did it to my, bless her, she's 31 now, but I did it to my daughter when she was 9 months, and again when she was 2.5, and she pulled the thing out, and I put it back in, and after that, she said, okay, I'll do this. She didn't when she was 9 months, but she didn't pull it out again. So I know it's a monstrous thing as a parent, and I know I was up all night looking at this child having this test, and she slept, she was absolutely fine. So it is a horrible test, particularly for a parent, but there needs to be something measurable, something where you can work out the risk of reflux, because we all reflux. I mean, you all eat the wrong food, we all do it. We know what the normal range is, but it's about risk, and particularly with TOFs. I'm sorry to come on to the TOFs so early, but that's why I'm here. It all depends, the risk actually depends on motility of the esophagus. You know, we can all reflux a bit, but then we swallow alkaline stuff and we get rid of the acid and everything else. And so we're normal, but actually if you can't do that, which is often the case with the TOF, then actually you're more at risk of these issues. So sadly, there needs to be something which is measurable. And I think that's the bottom line. I think if your daughter's on a reducing dose of Omeprazole and she's well, then someone probably just needs to measure how much reflux there is. On or off treatment, you can argue it both ways. You can do it both ways, and then make a decision where to go from there. And to be honest, these decisions for doctors are actually not so easy. There are many decisions we make which are massive decisions, but they're easy. But reflux is actually quite difficult because it's subtle. It's subtle, and there are many variables to be looked at. It's not how much reflux there is, it's, you know, whether you use it, maybe another question, whether you just measure pH, whether you measure impedance, which can tell you about esophageal damage, whether you measure manometries, which tells you about esophageal acid clearance, and you know, all these issues all come in there. So it's actually incredibly complex is the question. So I think your doctors are probably doing the right thing, but it's a really complex situation, and it's not for the faint-hearted, and it's as difficult for the doctors as it is for the children and the families.
My daughter's 13 months old now and has been on a dose of 3/4 of a tablet of Lansoprazole. Do I just keep increasing the dose alongside her weight or try and wean her off? She was originally diagnosed with silent reflux when she was 6 months old.
I don't know what silent reflux is. I mean, I see so many people refer to me with silent reflux, and I think without an objective measurement, you can't say what it is. It's totally subjective. So I think my first advice would be, if the symptoms are troublesome, you need a measurement to understand if it's an issue. Depending on those measurements, you can decide whether you have to increase the medicines or actually stop them. And I know that proton pump inhibitors, Lansoprazole, Omeprazole, Esomeprazole, and all the others have a reputation for being safe. And personally, I've had children on these things for 18 years until they've left me. One always has to worry about drugs. And so I think one needs to understand there is a bona fide reason why these drugs are being used. So it's not nice to suggest there should be an objective measurement because it's the nasty test I spoke about in my daughter. But I think that's the gold standard. That's what we have. And you can do it off medicines to see how bad things are, or you can do it on medicines to see how good the treatment is. And you get surprised both ways. Sometimes there's no symptoms. You look at the studies, and the medicines really aren't doing anything for the acid exposure or the reflux, but the child's well. And then sometimes the medicines are working for other reasons, and there are other. I think we'll discuss this later. Other reasons why a proton pump inhibitor might reduce symptoms. But then sometimes there's actually no reflux, and what's being reported actually isn't reflux, it's something else. So it's a nightmare situation, and I can tell you about this. I mean, it's 30 years. I'll tell you about my daughter. I mean, my ex-boss, who was my senior consultant, said, this is reflux, treat it. But actually it wasn't, it was food allergy. And after 2 years of him saying, take the PPI, take more, actually change the diet, and she got better. And so, one needs an objective measurement. One actually needs that. And I think that's the take-home message.
Okay, so I think the answer to the question in a way is that changing anything without a basis for doing so seems like an unwise idea, and if there's a concern, the answer is a measurement is necessary to work out and understand the degree of need.
I think it's a best guess otherwise, and
yes.
Superstition is fantastic, and we all live by superstition. All of us do. In medicine, sometimes you just feel it in your bones. There's something here you've got to find. But I think with reflux in particular, there are so many things which masquerade as reflux. Being objective, sadly, is the best way forward. And as I said, I did it to my child. So,
okay, that's an interesting point.
I've told that story many times because I know parents look at me with big eyes. We have to do this nasty test, but it's worse for the parent than it is for the child.
Okay, that's interesting. Thanks. Well, let's move on to the next one, and perhaps after this question, we maybe ask Professor Fullarton to answer one or two, and perhaps see if Duncan's internet is good enough for him to pose the questions too. But the last one in this block we've got relates to an 11-month-old who's recently been taken off Omeprazole because the tissues looked healthy apparently during a recent stretch. And the questioner is saying, if the mucosa looks healthy, might that be because of the Omeprazole rather than lack of, again, silent reflux? What do you look for when deciding a patient should stop taking omeprazole? Does it reach a point when it's no longer effective? In a silent reflux case, what we look for, perhaps deciding to start using the omeprazole once more.
Yeah, that's always very difficult because injury to the esophagus relates in part to acid exposure, and actually in part to exposure to other stuff which comes from gastric juice. And if you have a TOF, then some children with TOF will have poor acid clearance from the esophagus, and some will actually have very efficient acid clearance. It just depends which subgroup you are. And our experience in London, I have to say, is that most don't clear it well, but I know the experience in Holland is that the acid in the majority is cleared incredibly efficiently. So we clearly see different populations, and that's how it is. But if you're not clearing acid or gastric contents efficiently, then you're going to get injury. And we'll have to worry about injury because the long-term effects of injury may not be so good. And so, how does one gauge injury as a pediatrician? Well, you can gauge the risk by doing the dreaded pH impedance study, which is the tube down the nose for 24 hours. You can do it a little bit by doing the manometry, but that's a little bit specialized, and there is an argument for it. It's fascinating information. It does give you risk, actually. It does give you some risk. Or you can take some biopsies. Is there injury or isn't there injury? And if there's no injury, then you're in a very good place. And if you're on medicines with no injury, you may decide, particularly if the pH impedance is reasonable, you may decide to stop it. But then you have to follow that up and do another endoscopy, which I can understand as a parent. It's horrible because it's general anesthetics for the child, and it's an endoscopic procedure, which takes how long it takes me about 2 minutes, maybe 3, but it doesn't take long. And the anesthesia we use actually is the surgical anesthesia, so actually we just have limited sleep, but actually it's still a procedure, there's still risks. And I can see why a family wouldn't want to go through that, but actually think it's necessary, to be absolutely honest. I think it's the best standard of medical care is to do that. And we all bend the standards. We all sometimes, bend the rules a little bit. Okay, we'll wait 6 months. But actually, at the end of the day, it has to be done.
If we go on to Professor Fullarton now, is erythromycin a useful drug for someone with Barrett's esophagus? If it is, would it be in addition to a PPI? And which medications can be ability?
Yes. Hi there. Sorry, I missed the last bit there. But the question was related to Barrett's esophagus, I think, and erythromycin. Well, the answer to that is no. We wouldn't use that as a prokinetic agent in an adult. It doesn't really got any place in Barrett's esophagus. I mean, essentially, treatment of Barrett's esophagus is the treatment of gastroesophageal reflux. So we basically treat somebody with Barrett's. It's essentially reflux control at the higher level. So somebody with Barrett's tends to have increased esophageal acid exposure. They've got higher incidence of bile reflux. So the primary treatment of Barrett's esophagus relates to PPIs. The only addition, I would say, there's some recent evidence from the Aspect trial, which was a big randomized trial, a multi-center one that we participated in across the UK and North America, looking at the addition of an anti-inflammatory drug. It was aspirin plus PPI, and that may be standard of care in the future. The benefit of that is it does reduce the risks of progression to dysplasia. So I would say basically treatment of Barrett's, you're treating the reflux condition, but I've no experience of using prokinetic. We use prokinetics quite frequently. Erythromycin, no, I wouldn't be using that. It's not licensed for that. So treat the reflux. Consider adding in aspirin. That's reasonable. That's currently with NICE to consider in adults, and that may be relevant to your TOF patients. And that's basically what I would say at the moment. So good reflux control is very important in somebody with Barrett's. Reduce the inflammation, you reduce the potentially the risks of dysplasia and cancer.
For someone with Barrett, does PPI, i.e. lasting at night?
Well, Gaviscon's basically just an antacid, so it may be if somebody has symptom benefit with that, then fine, take it. But PPI dosage in Barrett's generally needs to be a BD dose, so it needs to be pre-meals. The timing, the optimization of PPI therapy is very important, and lots of patients I see, it's suboptimal. They don't get told exactly when to take the drug. It's very important you take the PPI 30 minutes before meals, because it is a drug that blocks the acid. The parietal cells, they're the acid-producing cells in the stomach, and the most potent stimulus to acid is food. So if the drug's not taken at the right time, the effect of the drug is very suboptimal. So it's very important that the timing of that drug, and in most patients with Barrett's will be on a BD dose, i.e. one in the morning and one at night. So 30 minutes before breakfast, 30 minutes before evening meal. If patients have significant reflux and they find Gaviscon helps their symptoms late on at night, yeah, sure, that's not a problem, but it's not something that we would recommend as a standard, really. Yeah, sorry, I didn't hear it. I've actually printed out the questions. Is it
the third one?
The third one, yeah. So I started Omeprazole 20 milligrams in 1999. It was increased to 80 milligrams a day, so double dose, addition of ranitidine and metoclopramide. Yeah, again, if patients are asymptomatic, it's quite a high dose, I'd say, but obviously the patient's in their early 70s. If they're symptom-free on that, they may want to try to wind down the Omeprazole a little bit. That's quite a high dose. And there are some issues with long-term PPIs, particularly in the elderly. There's some not particularly strong evidence, but there's certainly some evidence suggesting things like osteoporosis might be more prevalent in patients. So I would be saying to that patient, if they were in my clinic, why don't we wind this down a bit, maybe down to, and again, it's a step reduction with PPIs, because the patients do get tolerant and there is a rebound hypersecretion of acid. So you mustn't just stop PPIs immediately or they will get rebound. So I would say there that, you know, there should be some consideration to dropping that dose a bit.
The next question that we had on our list is, are there any medicines which particularly help dysmotility? And that's the subject of interest to some adult TOF people. That's to Professor Fullarton once more. Yeah.
Again, it depends what dysmotility aspects we're talking about here. I mean, patients with TOF, with dysmotility, they've all got dysmotility of their esophagus. But many of them will have gastric dysmotility as well, which often relates to most likely to the surgery that they've had as a child. So they will have poor gastric emptying, so poor stomach emptying, which will also play a part in their reflux condition, and also poor, what we call, clearance of acid in their esophagus, a normal protective mechanism in patients' the esophagus is that when acid refluxes into the esophagus will normally contract to clear it, but the clearance mechanism in patients with reflux is poor. So again, it depends which is the most predominant, but in post-TOF patients, it will probably be both. So certainly gastric dysmotility, to be quite honest, drugs for dysmotility are generally rather poor. We use things like metoclopramide and domperidone. None of these drugs are not clinically in adults majorly helpful. We have, for gastric dysmotility, started to look at newer drugs like prucalopride. Prucalopride's a 5H, it's a particular blocker of a 5-HT4 agonist. So it's a drug which can help motility. And that's a drug that I have found in clinical practice now to be most useful. In terms of esophageal motility, I'm afraid we don't have many drugs that are particularly helpful. We still use things like domperidone and metoclopramide, but they're not particularly helpful. We do need better drugs. There's some evidence that some newer drugs like baclofen can aid reflux by reducing relaxations of the lower esophageal valve, but these drugs are still very much in the experimental phase.
Okay, that's very interesting.
We need better drugs, but there are some that can be useful.
Okay, well that's very helpful. Thanks. Last question for you, if I might, Professor. Our question is interested to know about the side effects of acid blockers such as omeprazole or ranitidine in the long run, and how best should such side effects be managed if they exist? Yeah,
well, there are side effects, and I mean, most patients will have read lots of potential side effects, particularly of what we call the proton pump inhibitors, like drugs like omeprazole and esomeprazole, lansoprazole. These type of drugs are very potent acid inhibitors, and obviously in terms of TOF patients, they are often on these drugs for life. So there's concern, and indeed many standard adult reflux patients are on these drugs for life. So there's been a lot of interest in side effects related to such drugs. There have been a lot over the last 4 or 5 years of publications with slightly sort of tabloid headlines, which have been picked up by the tabloids, causing quite a lot of distress to patients, and often being a point of discussion in the clinics. But the areas that there's more evidence for side effects of proton pump inhibitors like omeprazole. One of the long-term consequences of drugs which lower gastric acidity is that there's definitely an increased prevalence of bacteria in the upper small intestine, what we call small intestinal bacterial overgrowth. And that's because gastric acidity is there for a reason. Developmentally, it's there to kill off bacteria. And the lack of it does create an abnormal environment in the stomach. So bacterial colonization in the upper gut is a side effect that we see not infrequently now. And that tends to present in adulthood anyway, with things like bloating and abdominal discomfort, and sometimes bowel upset, particularly diarrhea. And diarrhea for a long time was always assumed just to be an inherent side effect of the proton pump class of drugs. But we do recognize now that more of these drugs, more of the side effects of these drugs can sometimes be due to bacterial colonization. So that's probably one of the commonest side effects of proton pump inhibitors. The other stated side effects are, well, the other things that can happen are development of gastric polyps, what we call fundic polyps, which aren't really of any major consequence. We haven't seen any clinical implications of those. Other areas that have been described, as I mentioned, osteoporosis has been described, although the evidence for that is not particularly strong. But again, it is related to absorption of calcium and things, so that there is evidence that suggests osteoporosis may be an issue. So it's certainly something in elderly patients or patients on long-term dose. We want to have them on the lowest dose to keep them symptom-free. Other side effects are much less common. There's been, again, anecdotal reports of dementia, heart disease, renal failure. None of these have been subject to any careful medical scrutiny, and I would caution against patients worrying about them. So they're the main side effects. Things like ranitidine, the H2 blockers are much cleaner drugs in many ways, although ranitidine was pulled off by the FDA, not because of the actual ranitidine drug, but because of one of the constituents of it. There was some concern about it, but that's been remedied and it's back on the market now. So they're the main side effects with the PPI class of drugs.
Okay, that's very helpful, thank you. Interesting to hear. So perhaps I'd better switch back to asking one or two questions of Dr. Lindley now, if I might. And the next questions that we prepared from our members had to do with dysmotility. And the first one was from our members saying, how can I tell what is a stricture and what is motility? My son's been checked for a stricture, but it's not narrowed much. We're on the waiting list for endoscopy and for a test for esophagitis. I can never say that.
Okay. There are three reasons why you may not swallow so well if you've had a TOF repaired. One is purely mechanical, relates to the surgery and the almost inevitable complications thereof, where the suture line actually becomes scarred and strictured. And that's quite common early on, but less common with time. There's the underlying motility problem, whereby the esophagus doesn't contract normally, and this is highly variable. Almost everyone who's had a TOF repair, above the suture line, there's no contraction in the esophagus. But below the suture line, sometimes there is, sometimes there isn't. And just to put this in context, if I go to the pub and drink a pint of beer standing up, I don't use peristalsis to swallow. It'll just go to my stomach. Okay, I'll stay in my esophagus a little while, but I don't need peristalsis to swallow with gravity helping. So peristalsis is something you need either with solid or when you're semi-recumbent or recumbent. And so you can have had a TOF, you can have had a repair, and you can drink liquids absolutely perfectly, but still have no motility in the esophagus. And the third thing, and this is fascinating because 20 years ago it didn't exist, but now it's an epidemic. There's the business of eosinophilic esophagitis, which is an inflammatory condition of the esophagus, which for some reason, and I'm not obvious why this is the case, but for some reason it's more common in children who've had TOF. That may not be true. It might just be the children who've had TOF get more endoscopy, so we find it. But the fact is, eosinophilic esophagitis, which is something to do with allergic cells, but they're not maybe there, they may not be there just because of allergy. The allergy could be there. And the allergies don't have to be food allergies, they could be stuff in the atmosphere. There's a load of different causes. But they actually cause esophageal spasms. So if you get spasm of the esophagus, then it doesn't contract normally when you're trying to eat solids in particular. And so there are three causes, and telling them apart requires actually a systematic investigation, probably what you should have, and some of you may not like me saying this because it's not available everywhere, but you should have an endoscopy to look at the anastomosis and to take some biopsies to exclude the eosinophilic esophagitis. That's absolutely, that has to be done. You may, if you're lucky, be able to get a manometry, which defines whether the esophagus contracts or doesn't. And how helpful is that? Well, you can argue that until the cows come home, but the fact is, above the anastomosis, you're not going to see motility. Below the anastomosis, if you're lucky, you will. If you're unlucky, you won't. And you may see pressurization at the level of the anastomosis, which tells you that there's an anastomotic stricture, whether you can see it on the contrast swallow or not. The fact is, it's there, it needs to be dealt with. And the last thing, this is totally pretentious, and I would offer this to my top patients, but it's not routine in pediatrics. There's a thing called an endoflip, which actually involves blowing a balloon very gently across the anastomosis and just understanding how distensive it is. It's really easy procedure to do. It's very, very gentle. It does require general anesthetic because the catheter is not the most pleasant thing to push down the esophagus. So if you have an endoscopy, it actually adds probably 3 or 4 minutes to procedure, and it gives you the insight whether the anastomosis is tight or not. So I would say if you're having trouble swallowing and you have a TOF repair, you actually need the contrast study, you need the endoscopy, you need the biopsies, you probably need the esophageal manometry, and you may or may not require the endoscopy. And I spend my life doing this procedure for our surgeons. And even then we may have the odd difficulty, but usually it's well defined what one has to do after that. You see the good news or it's the good news. At least we know what we're dealing with.
Okay, I'm sort of picking up the answer there, and consistent with some of your other answers is you can't really give a sensible response without undertaking some tests to really start making some systematic progress towards working out what the matter is.
Sadly, this is a very difficult condition. There are many facets to it, and you just actually have to do something or do nothing. But if you do nothing, you don't know, and it is how it is. You give a PPI and cross your fingers, and often it's probably okay. But if you really want to understand what to do, then you actually have to do something. But you know, an endoscopy, as I said, takes me 3 minutes. Adult endoscopy will take longer because you're looking for cancer, but we're not. We're looking very specifically at the esophagus. It's a very short procedure. Blow the endoflip balloon out. That takes maybe 3 or 4 minutes in addition. And leave the esophageal manometry catheter down at the end of it. And then you wake up with the catheter in and we do the test, which runs for 30 minutes. So within an hour and a half of the procedure, everything is done. It's light anesthesia. It's not surgical anesthesia. So actually, the child, bless he or she, is just having a sleep. And actually, this is the stuff Michael Jackson used to have. He liked it so much. He felt so good after it. So the children, by and large, don't mind it. It's incredibly safe. And then we actually have a finite answer. You know, if there's a hiatus hernia, not forbid if we had a fundoplication, if it slipped, the manometry will show that. You may not see it on the X-ray, but the manometry will show it. It's 100%, but probably 99%. You actually get a real handle on the anatomy and what's happening. So our surgeons give me this job to do probably once a week, and actually, I think it's fun. They certainly want it done. They're very happy with what we tell them. And I think children are better.
Okay, well, time's getting on, but perhaps we could ask you just one more question that we've got, Dr. Lindley, before I go over to Professor Fullarton for a final one. And this is a question from another one of our members, obviously. How will I know if my TOF daughter needs a stretch? Is it just a matter of time until she learns how to chew and cope with dysmotility? That's one of the questions. She was stretched 4 times when she was a month old. She's 21 months now, wants to eat, but she gets stickies, in other words, food stuck, if she eats fast or with certain foods.
Well, I think the answer is the same as the last question, to be absolutely honest. You need to understand why. The eating fast is interesting. When we do the manometry test, which measures the esophageal contractions, and in the middle of the test, you make people swallow very, very fast. And what that does is actually inhibit the esophagus from contracting. So however well or however badly your esophagus contracts, if you drink very quickly, it stops contracting. This is my pint of beer argument again. You go to the pub, you drink the pint of beer, drink, fantastic, I feel good, but actually it's all in your esophagus because the esophagus has stopped contracting. So gravity might take it down. The same with gin and tonic, it doesn't have to be beer, but it's just the fact drinking very quickly inhibits the esophagus. So if you have dysmotility, which affects some of your esophagus, which in the TOF is universal, then eating more slowly may give you a solution. It might not. It might not if there's an anatomical reason. It might not if there's an inflammatory issue. It might not if there's total dysmotility of the esophagus anyway. But as I said, you actually have to define this to understand what to do about it. Otherwise, you just have to sit there and say, well, it's how it is. And there will be some children who do sit there and say, this is how it is. And they get by, they never need an intervention. But they just cope with their symptoms. And I have nothing against that. But if the symptoms are sufficiently bad to require something being done, then I think the full gambit of investigations actually tells one sensibly where to go with it. And to go back to the prokinetic thing, I don't know of a good prokinetic drug which helps the esophagus contract. No, I run a prokinetic service which relies on prokinetics in the rest of the intestine, but the esophagus, no. The baclofen question, yes, baclofen helps reflux. It's actually in the North American guidelines now, so we've used it for 20 years, but it is in the guidelines finally last year. But it's not a prokinetic for the esophagus.
Okay, so baclofen is the drug you're referring to there now, which has just come into the American guidelines as a helpful one. Did I hear that
I think
properly?
it was last year. It may have been the year before because I'm getting old now, I forget. But it's recently been in. But I say we've used it for 15 or 20 years for specific indications of reflux, usually after manometry where we see the mechanism of reflux. Because as I said, reflux is not a diagnosis, it's a symptom. You need to understand why.
Yeah, I think I'm getting a fairly consistent impression. Although the questions our members have come up with here are perfectly reasonable questions, it's awfully hard to give them a reasonable answer without undertaking some tests.
Exactly. And I feel for them and I feel for the children. But I do these things and actually. The children suffer less than the parents. And I can say that, as I said earlier, one of my children went through it, so I know what she went through. And I suffered more.
Okay, well, look, thank you very much. But perhaps we can lastly go back to Professor Fullarton and just check out one or two other questions before we close. Would that be okay? So thank you, Professor Fullarton. There's a couple of questions which adult TOF members of ours have asked relating to reflux, which may be really worth touching on. So one of them has asked, at what point should I, as a TOF adult, be speaking to my doctor about the reflux that I'm having? Is there some sensible thing that can be said about if you've got this symptom, then you really should see a doctor, whereas if you've got that symptom, don't bother?
Yeah, I mean, I think, certainly in the UK, I mean, it should be if the patient's reflux is not well controlled. I mean, I think, that if they're on standard PPIs and that there's no ongoing symptoms, then I don't think that doesn't really need any further assessment. I think, we aren't at the stage in the UK where we're recommending screening. Screening would only be helpful in patients with reflux, in relation to TOF, previous TOF surgery, if there was concern about Barrett's, and I know that these patients are at more risk of Barrett's. So, but it's certainly not in the recommendations at the moment that all these patients should undergo screening. Many of them will as a child, so many of these will be passed on, and a lot of patients the ones that I see anyway, usually, you know, are back not for reflux reasons, but for mechanical reasons, i.e. strictures. So I think the honest answer is that, you know, if patients are finding their reflux is poorly controlled on the standard drugs, they're needing escalating doses, then that's the sort of indications for further investigation. Further investigation, you know, in the future, it's not just going to necessarily involve endoscopy. We have been developing interesting new ways of screening for esophageal diseases. In Scotland, we're just about to launch a government-sponsored program using a technique called Cytosponge, which I've done some work with Professor Fitzgerald down in Cambridge. This is a capsule basically a capsule in a string that's swallowed, and the capsule dissolves in the stomach and creates a little sponge device, which is then withdrawn. It's a very well tolerated procedure, and that gives, basically, it's a cell collection system, so it gives a full screen of cells within the esophagus. Now, that's not been used in TOF patients, but it has been used primarily in Barrett's patients. It's very good at diagnosing Barrett's and dysplastic Barrett's, and it also seems to be useful for other esophageal conditions like Dr. Lindsay had mentioned, eosinophilic esophagitis, which is this kind of allergic condition of the esophagus, which often needs repeat endoscopies to assess treatment effect, and it does seem to be useful for that. So that's something for the future that may reduce our requirement for endoscopy. But the simple answer is if symptoms are poorly controlled, then best to get that checked out.
Okay, yeah, well, thanks. And the last one perhaps we should touch on is a kind of similar question as an adult TOF. Am I at risk of Barrett's? And a kind of associated question for those that are taking PPIs on a long-term basis, is it wise for them to take any supplements of any sort alongside the PPIs if they should be on them long term?
Yeah, so I slightly missed, sorry, I missed the first bit. Was it TOFs patients at risk of Barrett's?
We've got a TOF adult asking if he or she is at risk of Barrett's esophagus, of it developing later in life, if they do not take PPIs.
Well, they are at risk of Barrett's with or without the presence of PPIs. There's not really an awful lot of evidence that PPIs definitely stop the progression of the esophageal mucosa to Barrett's mucosa, which is a sort of a change in the cell lining. But there's certainly, you know, it's certainly likely to help in the long term. So, you know, it goes back to what I said originally, that we treat patients' reflux symptomatically. TOF patients are at risk of Barrett's, so it's important that their acid control as adults remains good. So they should be on appropriate doses of drugs to keep their symptoms away. So they are at risk. At the moment, we don't have any clear guidelines in the UK to suggest that all patients, you know, post-TOF patients should have some form of esophageal screening, but there certainly would be an argument for that. And I know that's not always the case. I think in Europe, I think it's Holland maybe has a screening program, but it's certainly not in the adult BSG, the Gastroenterology Association guidelines. But it certainly takes you back to the previous question about when should you seek specialist medical an opinion, and if patients post-TOF surgery reach adulthood and are having trouble with reflux, they should present themselves for further assessment. And the second question was related to, what was it? Any other drugs? Was
it sensible to take any dietary supplements alongside long-term PPIs for those that are on long-term PPIs?
There's not really any evidence that dietary supplements per se would have any impact on the progression to Barrett's or indeed reduce any of the potential side effects of term PPIs, which are mostly theoretical. The only thing I would say that that may move into standard clinical practice is the addition of a low dose aspirin tablet on top of a PPI. There's good evidence now that does reduce the risks of not necessarily Barrett's, but progression of Barrett's, because the relevance of Barrett's is the risk of developing esophageal adenocarcinoma, which is quite a common esophageal cancer now, and Barrett's does increase the risks of that. So we have been looking at pharmacological ways of trying to reduce the risks of that. There aren't really any dietary risks. The dietary maneuvers with reflux are just standard lifestyle changes, healthy diet, low-fat meals, not large meals at night, and not eating late on at night, and reduced levels of alcohol, tobacco, etc. late on particularly. So the addition of aspirin may be something to consider, but that's again not standard practice yet, but certainly it may well be in the near future.
Okay, thank you for that. Just in closing, I can't resist commenting that you're absolutely right. There's major progress in the Netherlands for routine screening of those adults born with esophageal atresia. We had the lady who set up the programs for that come over to speak to one of our events for TOF adults in 2018, in fact.
Right.
And so far as I know, they're by far the most advanced in the world in terms of responding to the needs of TOF adults in this kind of respect. And I'm sure we at TOFs would be most interested to chat with you about that further, but obviously not right now.
Yeah. No, I think that's and there are ways, of screening. We're basically Barrett's is what we call a clonal phenomenon. So it's basically just very small bits of the esophagus, the tissue that change into Barrett's. That can be quite difficult sometimes to identify endoscopically, and particularly when the simple Barrett's tissue changes to become more concerning tissue, it's particularly difficult to pick that up endoscopically. So using something like a cell collection system like this Cytosponge may in the future actually be a much more acceptable method and a better method at screening, and that may be applicable to TOFs patients. We're not really at that stage. It's just being used in standard reflux patients at the moment and Barrett's cases, but it's certainly an area to watch, because that would make monitoring of patients much simpler. Indeed, that might even be possible to screen younger patients with that technique.
Okay, well, that's most interesting. Well, I see that we've got to past 1950, so we really ought to wrap it up now, I think. So the most important thing for me to do is say thank you very much indeed to Professor Fullarton and Dr. Lindley. Thanks very much for your time, both of you. It's very good of you to help out our members in this way, and I hope all our members who are on the call today have been listening hard and taking notes of that. We have got it recorded, so I hope that in the fullness of time we'll be able to make recordings available to everybody, and when they didn't catch whatever was said precisely, they can have a look back and check that out. So thanks to both of you specialists indeed from TOFs. And for our members, could you please fill in the evaluations which have been emailed to you by my colleague Diane whilst the call's been ongoing, because we'd love to know what you thought about this. I imagine quite a few of you are going to say the internet has let us down somewhat on this occasion, which is why I'm talking at the moment rather than my colleague Duncan. But hopefully we've battled through that with some degree of success. So thanks very much to everyone. And I think that's an end for this evening.
Okay, thank you very much.
Yeah, thank you.
Okay, goodbye now.
Absolutely.
Okay, bye now.